or two people signing in. Maybe wait one more minute, Sarah Joy, and then we'll get started.
Absolutely.
I think anytime you're ready, maybe.
Absolutely. Okay. So welcome everyone to the third quarterly webinar of the EMR Network. Welcome to returning participants as well as anyone who might be new on this call. Hopefully everyone can hear us and has had no technical issues signing in. And so here's a quick reference just to Webex in case you haven't had a chance to use Webex before. You'll see a little comment bubble at the bottom there. So if you click that, you can see the chat box. You can use this to chat with us, all attendees. You can also chat with just the host if you're having any technology issues. You can also see all of the participants that have signed in. If you click, there's that little icon with the user with those three dashes next to his head. So that will show you those. And so before we get started, why don't we have everyone identify themselves in the chat box? So your name, your PCN, the EMR you're using. If you're in a room with several people, if you could identify everyone that's there, that would be fantastic. So we have from Kalina PCN, Vermilion Clinic, Acuro, that's from Ariel. We have Kristen Pennick from Rocky View PCN, or Rocky Mountain using MedAccess. Basira from Edmonton Southside PCN, she is a EMR consultant. We have the support nurses at Red Deer PCN, Lacey from, oh, they're all disappearing now. McLeod River PCN, we have Kelsey from Bighorn PCN using Wolf, Julie from La Vida Medical Center in Airdrie using Wolf. We have Kira using HealthQuest at Chinook PCN, Kathy from Southside PCN, Deborah from Ridgeview Medical Canmore, the Bow Valley PCN using Wolf, Tara from Edmonton North PCN using a bunch of different EMRs, that's fantastic. Anita from Westview PCN, Leslie from Edmonton Southside, Amanda from Kalina Country PCN, the Vermilion Clinic again using Acuro. We have Scott from Pinter Creek Clinic using Wolf, Sean from Canrose PCN using MedAccess, Caitlin from Calgary Rural using 3 different EMRs, Betty from Lakeland also using a few EMRs, Brianna from Leduc PCN, Sarah and Jolene from Bow Valley PCN, Anna from Grand Prairie PCN using 4 different EMRs, Sunday from Drumheller Associated Clinic using MedAccess, Christine, who is a practice facilitator for Kalina Country PCN, and Kimberly from Calgary Rural PCN using 4 EMRs. So great representation from across the province. Thank you, everyone, for chatting in. And anyone else who might have joined late or is still hasn't introduced themselves, feel free to use the chat box to introduce yourself. We'll see it in there. So thank you, everyone.
And Sarah Joy, just a reminder for anybody who has more than one person in a room. So I saw that one go by for Red Deer PCN. I'm just wondering if you have more than one person in your room. So don't forget to put that in the chat as well, because that helps to give us an accurate count of how many people attended the webinar.
Absolutely. Thanks, Mia. And then we have Marvi from Mosaic PCN also using 4 EMRs. Wonderful. Okay, so just a quick overview of the network, the EMR network. So the EMR network is there to support the advancement of the patient's medical home. And so the success of the network is really grounded in the participants, so that's everyone here. Their commitment to engage and communicate collective experiences, wisdom, passion, and all of this with the aim to enhance the care of patients by optimizing the EMR. So the network really aims to support practice facilitators, EMR users in the clinics and PCNs, as well as anyone who's interested in the advancement of EMR leading practices in the patient's medical home. And so just a note, because we have both practice facilitators we have both the Practice Facilitators Network and the EMR Network. We know that there will be some overlap between both networks for those of you who might be a part of both. But we want you to know that we are aware of this, and we will be making some distinctions. So a good example is the work for CII CPAR. So the Practice Facilitator Network will focus mostly on guiding clinic work with a quality improvement focus. So using all of the skills of facilitation, reflecting on measurement, and building high-functioning teams. Meanwhile, the EMR network will focus more on things like how to capture the right data in the right place to get meaningful measurement. So really more of that focus on data capture in the EMR. And Leanne, we can advance the slide. Thank you. Okay, so welcome to your EMR Network co-leads. So I am Sarah Joy Kurth. So not Sarah Jo, Sarah Joy. And I am an analyst at the AMA with the ACT team. And we have Mia Kavanaugh, who is a consultant also with the AMA ACT team. And she will be taking over the presentation shortly here. Okay, so we'll actually, Mia, are we still doing this slide?
No, I think we did good with that already. I think we can go past that.
Awesome, thank you. Wonderful, so welcome to today's topic, everyone. We're very excited about this one. So it is Principles of Management and Monitoring Patient Populations through the EMR. So we're focusing on opioids, but we're also looking beyond that. So we're really looking at these principles of management and monitoring through the example of opioids, but we're also going to show you how it applies to really a lot of work that you are doing in terms of different projects and that across the province. Okay, so here's a quick agenda for today. So welcome, everyone. We've done that, same with round table introductions. We'll start off with some foundational EMR work. Then we'll look at applying EMR work to any patient population with stories from the field. So we'll have a couple of presenters who will share some stories. And then lastly, we'll wrap up with some questions and talk about future meetings. Okay, so to get us started, we'll talk about some foundational EMR work. So first of all, it is important that you look at your EMR and you use your help files and you use the EMR resources that are on the ACT website, and you really start to learn your EMR. So learn the nuances of search logic. So use your search functions in the EMR. See where you can find data, where data should be located so that you can find it using the search function, what can't be searched, so what fields you won't be able to search from. And then when you're looking at capturing new data, so say you're starting a new project, really look at where should that data go. So once you have an idea of your EMR, it's easier to do that and to figure out which fields will be pullable and really help you in measurement. So in essence, learn what the EMR can do. Second is panel processes. So, there we go. So a validated panel is really foundational to any work that you start. Any of the projects that we start about or talk about today, panel is really, really foundational to all of that work. And so we want to it means shifting the focus from individual patient care to more population-based care. So that means managing the health of a defined panel of patients. So we really want to clean up the EMR so that then we know exactly what panel each physician has within a clinic, and we can really focus on the characteristics of that panel. So there is a link there to some resources relating to panel and continuity that can help you get this work started. And even if you have started this work, there are other more advanced tools on there as well. And then the third thing is we really want to emphasize that when you're working on a project, so say you're working on opioids, and then you decide maybe to work on another project, say CII-CPAR or ASAP, we really want you to be aware that it won't be starting net new work. Whatever work you've done in opioids or even in paneling, that work will transfer over to those other projects. So there's no need to be, scared of, oh no, we need to start a whole new project. Whatever skills and whatever data cleanup you've done in one project will apply to another project. And maybe there might be a few new processes to put in place, but really all of the work just builds onto each other or onto itself.
Okay, so Sarah Joy, I think I'll take it from here. So thank you, Sarah Joy, for everything that you've talked about so far. I just want to echo Sarah Joy's comments here, and just, a lot of what you're going to see today, I noticed a lot of familiar faces on the participant list here today, and I know that there's many of you who know a lot of these things, and actually that's the entire point of today's webinar, is that you have more tools in your tickle trunk than you think you do. And so as we move forward, there's always going to be a new piece of work. There's always going to be something that comes after, comes after opioids. We're always working and refining and improving and finding ways to streamline workflows and efficiencies. And as we move forward in that work, you guys have got a lot of those tools already. And of course, there's going to be a few of you on the call who are maybe brand new to this work. And so what we want to do is just emphasize that we've already started building those skills, right? And so how can we bring those to bear in that future work? So the other thing I'll just quickly mention is that you'll see in the previous slide, there was a link there for some panel and continuity resources. There's some further links down at the end of the webinar. This webinar slide deck will be posted to the Collaborate page, so you'll be able to access those links. And then maybe another just a little quick thing would be to grab your phone and do a quick little snapshot, if that helps, on your camera, so you, in case you don't have a chance to go find that webinar later. Okay, so just to continue on, so I think the first thing we need to do is just tip our hats here to the sequence to achieve change. Again, I know there's a lot of you on the call who are practice facilitators, and you likely have seen this before in some of the PF Network webinars as well. And once you start talking about how to implement work at a clinic level, the EMR becomes the obvious tool that we use when the rubber meets the road. It's how we make it all happen, right? But from a standpoint of the sequence, it helps us to move the work forward. But when we look at it from the EMR point of view, we need something as well that aligns with the sequence, but yet addresses the EMR specifically. And so what we're hoping today is that we'll just show you a couple of very simple principles that you can apply in all that work going forward, and yet not lose sight of that sequence to achieve change. Okay, so just a little note about what ASAP did for us. And again, I'm going to make the assumption here that most of you have seen Alberta screening and prevention work, and you've maybe done some of that work in your clinics, or have had somebody help you with that, or have observed it. And so just a bit of a recap here, because this is something that we've been doing for a little while. And so what did that teach us? And so if we look back on it, well, there's a lot of things that actually taught us, and it introduced us to a lot of different things that we maybe weren't doing before. So, for example, it really had us start thinking about how to target segments of the panel. So how do I pull out all my, my female patients out of the panel and look at that through the lens of PAPs and mammograms, right? How do I look at certain age groups? How do I exclude people? How do I exclude patients from mammograms if they've had a bilateral mastectomy? Those are things that were almost sort of new ways of looking at things, because the panel was very much a sort of patient by patient way of approaching it versus looking at the whole patient as a whole. So it also taught us about opportunistic and outreach work and what that could look like, and how we could capture somebody who happened to be in versus somebody that we wanted to reach out and bring back in because they were overdue for screening. We started to develop a lot of point-of-care reminders, so that's rules, reminders, CDS triggers, goals, pending notifications, all those pieces in the EMRs that started to help support the physicians in their daily work, right? Or even support them with clinical decisions potentially. And it was never that that they didn't know what to do, but it was always just that extra little bit of support that the EMR would, oh, don't forget this person's due for an A1C. Great, I'll fire you off a requisition and we'll get that done, right? So that your screening's up to date. It also helped us identify the gold nuggets, and that's my own kind of special term for gold nuggets. It just means that, when we started to run a list of all those patients in the outreach maybe, how many patients who are overdue for a mammogram, we would find like a handful of patients that hadn't had one in 10 years, right? So not only were they overdue, they were really overdue. And so that really gave us a way to kind of pull out just those, what I call the gold nuggets of really starting to capture those people who are really needed some attention. It also encouraged us to reflect on data. So this is one of the, other than doing some panel work, because we were starting to pull like panel validation rates, ASAP actually started us pulling things like mammogram screening rates and cholesterol screening rates. And we started to be able to reflect on the data that we could get out of the EMR itself. And it also, as a side note, also gave us an insight into maybe where things weren't standardized. So overall, we started looking at the panel as a whole, right? Not patient by patient. We weren't just treating the patients that were coming in front of us that day. We were maybe looking at things a bit more proactively, and we were looking at ways to reach out to those patients to see if we could round out their care in many different ways. So all of the things that we learned here was actually a lot, and everything that we learned can be applied to any segment of the panel. So that could be a panel of patients with diabetes. It could be a panel of patients with multiple sclerosis, those prescribed opioids. So as you start to think about this work, you can really extrapolate into these other segments and start saying, okay, if my doctor wanted to all of a sudden track people who had Huntington's disease, for example, then how would I go about doing that? Well, the principles will remain the same. So it doesn't matter what the target is, it only matters that you really look at those principles and apply them in a similar way. Okay, next slide. So the 5 principles of monitoring management of any patient population, and guess what, guys, you know what these are. So ongoing and strong panel processes, we're gonna go through these one by one. The EMR tools, standardization, EMR features, and measurement. Okay, now I'm just gonna pause here for 3 seconds and say there's gonna be a place where we can ask questions, but I really want to encourage you all, if you have questions along the way, please put them up on the chat. I will absolutely stop what I'm saying and we'll try to address your questions, okay? All right, next slide. Okay, first principle. So we talked about this in foundational work. If you remember, Sarah Joy talked about that in terms of as being, one of the things that is foundational to everything that we do going forward. And so the reason that I put this in as a principle for as we go forward in any of this work is that, yes, that is foundational work for us to do, but we have to remember that it's ongoing, that this requires maintenance and that the work in panel never stops. And as a matter of fact, once you start looking at targeted areas of the panel, you will start to notice where, people have maybe not been validated, or we need to double check in with them to see, if you haven't had that mammogram in 10 years, is it because we haven't done that for you, or is that because maybe you're doctoring somewhere else, right? These are questions that we might have. So those panel processes have to remain strong and they have to just continue on. But you also need to communicate with your team about why validation is important and how it applies to the work. So the example that I would give you is a clinic that I worked with at one point. They had basically 90% buy-in from the team, but they had 2 people at reception who, were really weren't involved in any of the conversations about why it was important to validate. And I went in one day and I said, so how are we doing, and how are we doing validating patients? And what I got back was, this is stupid. I don't see why we have to do this. And so, oh, okay, great. So we need to involve you in this conversation about why that is. And so as we talked about the ASAP work, I explained to them, I said, so when we do our outreach, if we haven't validated these people, we know that, demographics get out of date often. And if we have somebody who, has a critical result or they're really overdue for screening, we have the potential to, save a life even if we can get early detection on breast cancer, for example. So, if my family was coming to this clinic, I would want my family to come here all the time because I knew that's the kind of care that they were getting. And as soon as they heard that, they totally got it. And then we had basically 98% validation after that. So it's really important to communicate with your team in every piece of work. So if we're talking about opioids, for example, then that is a really great way for us to tie into why that's important for opioids. So, we have people who need some additional monitoring. If monitoring goes really well, we have an increased chance of them being successful on maybe taking Suboxone and getting off the opioids. Again, how would I want that to happen if this clinic was where my family went to? And as soon as you tie it back to that, it always works. It always works. So don't forget, if you haven't already started with a clean panel, then you need to begin that work or continue what you've been doing. Just know, some people say, well, maybe I can't start this work if I don't have a clean panel. And the answer is, you can totally start this work, but where you will see when you start to pull some of the lists and reflect on your data, you'll see where you may have a lot of people on the list that maybe shouldn't be there. And so that's one of the reasons why the foundational work is so important and can help you move along quicker in all of those pieces. Okay, number 2, EMR tools. All right, so this is a step, and I forgot to share that one of the things that I'm helping to support within the AMA is the opioid demonstration project, and we have 20 clinics actually that are working to implement some processes, which is fantastic. And so I'm just going to point out some of the things that I've been noticing as we look across 20 clinics. Is one of the things that I'm seeing quite often is that we forget the step to talk as a team, and that's part of the sequence to achieve change, right? Is we talk and we have an improvement team, and we make use of that team in a very robust way. So, but we need to talk with our team and identify what tools you're going to need. So, for example, that could be EMR subject-specific assessment templates. So, in the in the opioid work, those are things like the PALM-E template. That's the cows and sows. That's the contract or the conversation checklist, as it's called right now. So you would want to talk with your team. You'd want to talk with your physicians and say, which ones do you want? They may not want them all. I mean, we have all these tools that we can bring to bear, but the physicians might say, I really want that conversation checklist / contract for now, and we'll build on that later on. So have that conversation, because if you all of a sudden load 10 templates into the computer without talking to your doctors, they might be like, why did you do that? I can't use all these things. Okay, smart forms, exam templates, observation templates, these are all things, different language within the EMR to basically what tools am I going to use? If you are a clinic that uses a lot of observation templates and MedAccess, maybe that's a really great way for you to layer in that work because it's already part of your workflow. If you are a clinic that uses encounter assistance or smart forms, that may be the way to go. But you have to talk about that as a team because you don't want to completely upset the workflow. You want to augment versus recreate, right? And that would help you implement anything. Also things like assessment scores. So for the PALM-E template, for example, you might want to find a way to enter in the scores so that you can graph them. You might want to be able to enable some of those point of care reminders. So what are those things that you need? And all of those things are going to be part and parcel to those EMR tools. Okay, next one, standardization. All right, this is like the motherboard of the computer here. This is probably one of the biggest principles that we struggle with the most. And one of the things that keeps coming up over and over and over again, especially once we start trying to pull any data out of the EMR, but it has to be a conversation that starts at the beginning. So a couple things I broke this down into. So in terms of monitoring, that means what do your patients want? So that could be part of the patient experience, right? What could make this experience for them better? But also, what do they need? So do they need the reminders? Do they need people to phone them? Do they need anything else? So what are those things that they want? What are those things that they need? Those are two very different questions and elements. In terms of management, what do the providers want? And then what do they need, right? There's also a difference. So if the physician says, well, I kind of need this because I need to report on it, but I really want this. I really want to be able to keep an eye on these patients for X, Y, or Z. Those are two very different things and two excellent questions to be asking your providers. So that's how I would suggest breaking it down. Measures and reporting. So is the data that you need in a reportable field, okay? This is part of that learning your EMR. This is part of like knowing where to, like what is searchable, what is not searchable. If this field is not searchable, if you have a physician putting something in a SOAP note and they say, I want to put this in, or I want to get this back out of my EMR, then you can say, oh, sorry, we can't search from a SOAP note, but we can search it from here. I'll just tell another story here. I had a physician one time who said to me, you know, I really want to keep track of more social determinants of health. I really want to know who in my panel has low income. And I said, great, fantastic. That's an awesome thing that we could be looking at for you. Where do you put it? And he says, well, I don't put it in the chart anywhere. And I'm like, oh, well, then we can't pull it out of the EMR if it's not going in somewhere. And so sometimes those are conversations that you need to have. And then also, do you need to adjust your searches for previously collected data? So in one of the opioid demonstration projects, one of the things that one of the clinics sort of struggled with is they had put information in a risk field in PS Suite in this particular case, and they realized that it was something that they couldn't pull the data that they were looking for, and so they had to make a choice to put that information in a different place. And not only did they have to change where it was being entered, they wanted to go back and take the information they had previously collected and then transfer it over into the new fields opportunistically as patients came in. And so if you are building your searches, it would be really important to know, you know, where was that previous data? Can we pull any of that so we can have a sense of, you know, what's already there? And then where is it going now? So there might be that sort of transition period with any of this work that might be happening. Okay, so I just want to pause for a minute because I've talked about a lot of stuff so far and there's more to come, but I just want to check in and see if there's any questions so far. Please feel free to like throw something up in the chat. Is this making sense? Is this sound like, you know, yeah, are you all nodding your heads in the background and going, yep, that makes perfect sense. Yep, that sounds like my clinic. I'd love to hear if anybody have any comments. Don't all talk at once. Okay, Anita says good so far. Absolutely, Kristen. Standardization is key to efficiency in our clinic. No free text wherever possible to be able to mine clean data, absolutely. Rosie says, I'm nodding in the background. This is really helpful, by the way, because I'm staring at a monitor, so I want to make sure that this is resonating. Scott, when you said if you did not type it in the chart, we can't pull it out. However, you could pull data from another source by linking through PCN, just a comment. Absolutely, you're totally right. And so it's in the case that in the story that I had talked about, there was no place where we could pull that from, right? And sometimes when our physicians start to understand the power of an EMR, then they're like, oh, that's great. If you can pull this, well, can we get this too? And so sometimes we have to say, well, that's amazing. I wish we could pull that for you, but maybe we can't get it out because we have no place to mine that data yet. However, that's an awesome opportunity to say, if you want to start entering it in your EMR in a field such as this, then we can absolutely pull that for you, starting in the next couple of months once we start populating the charts. So you're absolutely right, Scott. Okay, all right. So next slide. All right, so the fourth principle is EMR features. So depending on the EMR that you are in, what are the specific features or tools that you can use to leverage to support the work? So maybe in PS Suite, it's toolbars. Many EMRs have flow sheets, CDM worksheets, SOAP templates, exam templates, encounter assistance, macros. There are a ton of things out there. And it is actually quite rare that going into a clinic where people say, I know exactly what this EMR can do and I use it to its fullest capacity. That doesn't always happen. And so quite often you can find features in the EMR that you never knew was there. And matter of fact, we have Chris Diamond on the call today, and I called him up the other day and I'm like, do you know if MedAccess has this kind of feature? I've never seen it, but do you know if it's there? And he goes, matter of fact, it is. You just have to turn it on. So it was so surprising sometimes what you are not familiar with in the EMR. So this goes back to that, learn as much about your EMR as you can, because you may find a little piece of functionality that saves you a ton of work. And so it's really worth the time and effort. So all of those things will help support providers or part of your multidisciplinary teams from your PCN resources, possibly with clinical decisions. You might find efficiencies and streamline your workflows, find faster ways to enter data. So look for those unique features of your EMR and then try them. So one of the things in the sequence to achieve change is to PDSA something. So that means that, if we turn on the toolbar, it's not going to be on from here to eternity. If you hate it, we can modify it, or we can turn it off, or you can trial it for a week, and then if you love it, then we can keep it there. So, those are all things that we talk about in terms of process, but look for those unique features and then try them out. One of the best things that I have ever found is that if I ever get a chance, and physicians will be going from room to room, and every now and then they'll pop their head into where you're sitting, and you might say, have you ever seen this before? And they go, ooh, this looks pretty cool. I kind of like that. And so I'll say, would you like to try it? And then their interest is piqued, right? So that's just maybe a way. All right, next slide. All right, so our fifth principle of measurement. So ultimately, how do we know we're going to be successful in the work that we're doing? So if we think about the work of opioids, we have a lot of resources already out there, and there's actually an EMR set of EMR guides as well as measurement pieces within those guides. And so some of the measures that we look at, I'll maybe talk a little bit about that in a minute. But these are measures that help us understand, like, are we actually successful in what we're trying to implement here? So, for example, most clinics, up until the time that for sure all the opioid demonstration projects, none of them had actually made a point to, up until they started, to run a list to say how many of my patients who are currently prescribed an opioid. That was just never a list that they had run before. So it's not that they had no idea, but it was just not something that they looked at or targeted. Actually, that's not entirely true. Not all of it, but many. I would say like 9 out of 10 of the opioid demonstration projects. And then how many of those people were identified with opioid use disorder? So in some way, that was just a new way to look at that population of patients. But the work itself wasn't new because we knew how to do that. We knew how to run a list from our medications, right? We knew how to run a list from our problem list. So again, just pointing out that with everything that we learned through ASAP, that really helped us build on how we were doing the work in opioids as well. Okay, so ultimately, what do the physicians want? The physicians might want something different than what the PCN wants, or different than what the pilot is asking for, if the pilot work is asking for. have a good understanding about what roles are going to be impacted and who might require some EMR training. So if measurement is a bit of a new thing for the clinic, then maybe there's a little bit of skilling up that needs to happen around building searches. That's actually probably the thing that I see the most frequently, is just being able to support staff, either from the PCN or within the clinic, to learn their search logic, right? So again, that goes back to learning as much about your EMR as possible. Okay, next slide. All right, so taking all these principles, again, I'm just going to say, you guys know all this stuff. You know how to do it. So many of you have got these skills already. So it's just a matter of applying what you already know. So if we look at the opioid work, for example, how do we apply that? What does that even look like? So let's just very quick and dirty, because I think it's really important that we don't try to analyze or get into the weeds too far, because you will know this stuff. So number one was ongoing strong panel processes. Yes, that's going to be foundational and it's going to be ongoing. EMR tools, absolutely. So in the opioid work, we're talking about the PALMI tool. We're talking about the opioid risk tool. And for those of you who aren't familiar, the opioid risk tool is an assessment tool that the providers may use prior to prescribing an opioid to see if that's an appropriate course of treatment for them. Once a patient has been prescribed an opioid, then later on comes the PALMI tool. And the PALMI tool would help them assess for risk of misuse down the road. And then, of course, that gets correlated with DSM-5 criteria, and that ultimately results potentially in a diagnosis of opioid use disorder. The conversation checklist, which was formerly sort of known as the contract, most clinics have that in their EMR. There's been a new one revised that was revised specifically for this work that's found on the ACT website. And so these are the kinds of EMR tools that you might specifically bring to bear on this specific population of patients within your panel. Okay, and standardization is cleaning up the medication list. I can tell you that in the opioid work, this has been by far the most difficult thing for every clinic to do, especially if you have more than one physician in the clinic. This has ended up being something that has taken quite a significant amount of time to do, and there's a reason for that. Is we know that what frequently happens is that medications that get prescribed don't automatically fall off the active medication list, and so they have to you have to go in there and manually discontinue them. So people come up on the list who haven't been taking it for a long time. There's also providers who are writing triplicates for prescriptions, but those don't get into the medication module. More often than not, I see them scanned into the chart so that they don't have to duplicate entry them. So if you're pulling an accurate list, then it takes a bit of work to get those cleaned up. So things that you might want to standardize are things like your PALMI scores, as I mentioned before, if you want to graph those. If you want to track how many patients, for example, who are currently prescribed an opioid who have had a PALMI assessment done. So that's something that physicians sometimes really want. It may not be something as part of the pilot work or PCN work, but every doctor just might want to know that every patient who is on an opioid has been given a PALMI assessment. They might want to know that every patient with opioid use disorder has a care plan. So there may be things that they want to see have happened. So that's part of their wants, right, versus their needs. Also, EMR features. These are things like the toolbars. We already talked about this, exam and observation templates. Absolutely. PS Suite has an opioid toolbar that's out there that can actually be shareable, and we actually demonstrated that on the PS user group last month. And so exam templates, observation templates, these are all things that can be brought to bear to help streamline data entry. Measurement. So we need to build the right searches. And what I mean by the right searches are, it's part of that learning the logic of the EMR. So, so in a lot of the demonstration projects, a lot of the clinics would say, sure, we can build a list of all those patients with opioid use disorder. And then they pull the list and they're like, this doesn't make sense. Like, nobody came up on my list. There can't be nobody. Right? And so then you have to sort of backtrack and figure out Did we build the search correctly? Did we tailor it to this particular clinic and where the data is entered? Is it different between this physician entering data and the other physician entering data? Maybe I have to build 2 separate searches for them. I don't know what that looks like. So these are all the things that you would need to take into account. Okay. So Deborah says, just wondering what the conversation checklist is and where we can find it. Also, okay, great. Thanks, Deborah. And there's 3 of you in the room. Perfect. So the conversation checklist used to be called the old, I want to say opioid contract is what the term most physicians were using. The CPSA had one of those and still does on their website. There was a new one that was built, which is currently resides on the ACT website. So if you go to the ACT website, you go patient's medical home and then the primary opioid response, then you will find a full set of materials there that were developed for practice facilitator training as well as for the opioid demonstration projects and tools that can be used across the province in any clinic. And so there was a new one developed there. So Deborah, if you and I would like to connect offline, I could send you a link to where you could exactly find that. Perfect. So yes, you're using one of those, but just using the old name still, exactly. And so my understanding is that there's some work going on that the CPSA may be working to adopt the new one that was developed, just because it had more patient-centered language and it was not sort of gender-specific. So, for example, the providers are always referred to as he instead of they or he or she. Okay. All right. So, right, so just make sure we have all the right searches built. Okay, so I want to get to a couple of stories here. So I just want to double check. David, have we got you on the line? We may have an issue with David. Technical issue. Okay, just in case David has dropped off for some reason, then I would like to just go to Kristen, and then we'll double check if David has had a chance to re-sign in. So Kristen, if it's okay with you, we'll go to your little story here out in Rocky Mountain House. We'll go to the next slide, Leanne. Perfect, okay. So you've done a lot of really cool things over in Rocky Mountain House. You were also participating in the opioid demonstration project, but you came up with something really unique that I thought I'd really like to share with the rest of everybody. So tell us a little bit about what you did.
Well, we created videos as tutorials for anybody who was working in our opioid pathway development using Camtasia or Snagit, if anybody's familiar with either of those. And then we host them right in the EMR so that anybody can see them regardless of what clinic they're working in, whether in the hospital or they're at a First Nation center or in a different community. And they have access, and then it just standardizes our care.
Perfect.
Not really sure what else to tell you.
No, that's okay. So I think it was, there was a reason why you developed them. So some of the challenges, maybe talk about some of the challenges that you were having and why you felt the need to develop these videos.
The biggest reason was that to get everybody in the same room at the same time for education is very difficult. We are one PCN with one main clinic, but we have a lot of satellite clinics in a very large catchment area. And so between covering hospitals, First Nations clinics, smaller communities, having the PCN no longer located within the clinic, trying to get 40-plus people together at once to teach them education so that everybody's using a standardized process is very difficult. And it was starting to be impossible to get things moving across the board. So I came up with the idea of doing videos so that I just send an EMR message to everybody, and they can go into the resource section of MedAccess, which is the EMR that we primarily use, and they can look at the videos and view them at their leisure and learn the steps and learn how we're standardizing the process. The first video that we did was for the opioid project, and it does take quite a while to get them developed, but once they're made, I probably commit 6 hours-ish going through and making them in about the 10-minute range in length. And then once we host them, then everybody can see them and they're easy to use. So this was our way of standardizing how we were cleaning up our charts for active opioid prescriptions. We found that a lot of our patients had an active prescription, but it was actually expired. And so we needed to clean those all up in order to get an accurate count on patients and what our opioid prescribing rates really truly were. And so by developing, it's a very detailed step-by-step, right from where to find to be able to create your macros and all the way through the EMR and through all the different tabs of a patient chart, including using reports, et cetera, so that we can all use it in the same way with the same wording, so that if we use NetCare, we're using the NetCare check task. For discontinuing an expired opioid prescription, we're using the same language, that's the reason why. And then there's no confusion and everybody understands the process as we move along.
Awesome. So you guys out in Rocky Mountain House are on MedAccess. So maybe tell everybody, where exactly did you put the videos and how people could find them? Now, and they're find them in your clinic. Let me just qualify that statement.
Yeah. So in MedAccess, pretty much on any screen, you have your blue circle help icon, which is the question mark. And when you click on, when you right-click on the icon, there is something called reference links. And when you open up reference links, it gives you this great page where there's all of these links that MedAccess puts in, but then we have quite a list as well of things that pertain to us and that are our physician's choice. And so then we just have a heading that says Rocky PCN information, and we put all of our video tutorials under there under different headings. So we also use them because we are a teaching facility, so we always have residents and students coming in, and we have new physicians that come in. It gives them a great chance to understand how the EMR works, how we use it, because it is used differently in different settings, but how we use it and where they can find things, how they can use them, what they need to be looking for, where they can find certain visits, so on and so forth, so that they have the best opportunity to use it to its most functionable state. And so we just found the reference links. That's always there whenever you log into the EMR, no matter where you're at, and you can view the videos. And in order to get them onto the reference links, we host them through a private YouTube portal, because we don't have a learning portal here at the PCN. So what we did is we created a private YouTube portal, and that allows us to support and host these through the EMR.
Awesome. Thanks, Kristen. So Lori just had a question about whether or not we can embed things like this in other EMRs. Now, for me, this was the first I had heard of anybody doing something like this. And so I'll be curious to know if there's anybody on the call who is aware of a way that we can do this. But I think Kristen also has a great point that, if we can't embed them in the EMR per se, there's maybe no reason why we couldn't do little videos like that for our own clinics and then put them on a YouTube video, even if it's just sort of audio with a slide deck or something super simple. So, but it's an excellent way to help educate everybody in the clinic, whether it be your residents or just getting the whole team on the same page about what's happening within a project. So I just thought that was awesome to share. So thank you very much, Kristen. Just as I'm talking here, please, if anybody has ever heard of doing that in a different EMR or in a different way, we would love to hear about it. Also, an excellent discussion board topic.
Yeah, and like you said, setting up a private learning portal through YouTube is really easy. And then you can share the links to your little tutorial videos through EMR chats or through email or however you'd like, and it works great.
Yeah, exactly. And that's always a challenge, right, is getting, and keeping those videos short, getting everybody on the same page. But even just saying, docs, you can look at this video. It's like 3 minutes long. You can watch it at your leisure when you've got a minute, that sort of thing, or while you're eating lunch. Okay, so thank you, Kristen. Thanks for sharing your experience. I thought that was super interesting. So I really appreciate you sharing that today.
You bet.
Okay, So unfortunately, I think David may have got pulled away from something else. So I just wanted to very quickly just talk about, very quickly about what he was going to say. And David Johnson is one of our co-design team leads, and he's out in Cardston Clinic in Chinook, PCN. And really the couple of things that he wanted to talk was that really the 30,000-foot view doesn't really work. And so what I mean by that is if you say to a physician, do you know who your patients are who are prescribed an opioid? More often than not, they'll say yes. But then once we actually pull the data and look really specifically within the EMR, it illuminates things that we didn't realize that are coming out in the data. So he had said to me over the phone, he said, it's like having coronavirus in your community. He said it's something that's much more prevalent than maybe you think it is, that it's something that, you know, needs attention. It's not something that we can sort of sweep under the rug. This was just sort of how he characterized it. One of the things that, and he's been doing this for a while, by the way, but he said when he originally ran a list of all those patients who were prescribed an opioid, he says the doctors actually had what he called sticker shock. And this was 7 or 8 years ago when they originally wrote this or pulled the data. But he said it really galvanized them into action. And so they spent a lot of time cleaning up their med list, again, which he said took upwards of a year to actually complete that piece of work. And so this is really just to set some expectations around the fact that this can take some time. So, you know, if you feel like you're going to implement some work, you might say, okay, we're just going to take the next couple of days and clean up our med list. It might take a little longer than that. So, you know, give yourself a bit of a pass if it takes a bit more time. Okay, all right. So I'll just go to the next slide here. So we've got about 7 minutes left, so I just want to start wrapping up some things here. If you've got some questions you want to ask, just please go ahead and throw them in the chat. But I'll just finish up on this slide here. So lessons that we've learned so far through the opioid demonstration project. So identifying patients prescribed an opioid, that can be a challenge because if our med lists are not accurate, then that can sort of stall everything that we want to do going forward. EMR standardization challenges. A lot of that revolves around the med list. Like, are we putting in the triplicates? Are we discontinuing things? Are we entering things that maybe get prescribed from a hospital site, for example? These are all challenges that the clinics are facing. Connecting with community resources. So look for other sources of data. Actually, Kristen, that's one thing that we didn't talk about, but Kristen had an experience where when they had sort of an idea through the data in the EMR, how many patients they had that were struggling with opioid use. And then when they connected with their community partners, the community partners had some data to share. And that was a good example, as talked about previously in the chat here, about other sources of data potentially. But when they correlated it with their own data, they realized that the mental health services, the community resources available to them had like double the number of what they had. So there was it was a bit of an eye-opening experience, Kristen, correct? Because they were like, we think we have this many, and whoa, it's like twice that number, you know, in a different, looking at it from a different lens. Right, Kristen? Oh, maybe she's on mute, or maybe she had to go run for patients. Okay, so anyways, Scott says, an important list monthly is patients prescribed Suboxone in Emerge or clinic in the past 33 days because of exactly what you said about the med list. Absolutely. So exactly, these are the things that we're seeing as people are starting to implement this work, for sure. Thanks, Scott. So being really consistent in the patient and EMR workflows, that sort of falls in line with our standardization, that sort of falls in line with everything that we know so far, is that if we have one physician or team doing something and another team isn't, that's going to cause us issues in data mining. And then getting other PCN resources or mental health or community resources involved, and maybe looking at some of the data that they're getting, see if you can correlate that. See if there's something that you aren't seeing or something that that will help modify your data in some way. Okay. All right, so just time for a little bit of questions. We've got about 4 minutes. So I've got maybe 2-3 minutes here, and then I have a couple of slides to wrap up. So please go ahead and ask any questions you like. You might have questions about how to implement this in your clinic, where you can find resources. All right, we got lots of super smart people on the call that know exactly how to go about doing this for the next population of patients. I'm very excited. Okay, if you've got questions, please still continue to put them in the chat. I will continue watching that. I just want to make sure we get through the rest of our slides here. Okay, so just a reminder, IHI School, Open School is still available. The licenses are a little bit limited, but those are available to you. And available to us until January 31st of 2021. Thanks to Lori for helping let us know when that was extended to. All right, so again, you can find some of those links on the ACT website. Okay, Rosie says she'll have more questions once they start the work, but all of the information was helpful. That's great. Awesome, thanks, Rosie. Okay, just a reminder about the Patient Senegal Home podcast. I believe there was another one that came out either Friday or Monday. It was like within the last couple of days. So again, you can find this on the ACT website. So have a look for it. If you go to the search bar of the ACT website and put in One Nail at a Time, it should bring you right to those links, and you can find that on a number of different platforms. Okay, there's some pretty cool people talking about some pretty cool things on these podcasts. All right. Next slide. All right. For anybody who has joined the EMR Network call, this quarterly webinar today, and you aren't already part of the network, maybe somebody said, hey, come, this is awesome, you need to come listen in, then don't forget to go back and sign up. Okay, so one of the awesome things that you'll have access to is the Collaborate website. And there's a main network discussion board. So this is sort of EMR agnostic kinds of questions. Also, there's EMR specific pages, user group pages. There's resources and recordings like this one from the webinar, as well as some of the PowerPoint presentations. There's also tons of EMR specific resources and like a breaking news kind of tab where we can talk about upcoming conferences. So there's lots there. Okay, next slide. Awesome. So managing your notifications. If you haven't already done so, please go into your EMR specific page and turn on your notifications. Okay, you can set the frequency so you don't have to get it every day. You can maybe get it once a week or something like that so it doesn't bomb your inbox. But please put them there because people are going to be asking questions. And the more smarty pants we have on the discussion board, the more we can help each other in answering some of those questions. Okay, EMR Support. So if you just go to Google, type in ACT Alberta, you can get to the new website, look under EMR Supports. That is where you will find a lot of EMR specific resources, including the main tip sheets as well as videos and the EMR Network sign up if you want to share that with anybody. So please spread the word far and wide. If you would like to send them that link, that is where you would find it. All right. Perfect, thanks, Leanne. So the next upcoming webinar is generally the second Wednesday of the month. We try to aim for quarterly. It's not always perfectly timed that way, depending on forum and other things that happen. But our next one is June 10th, and that one's going to be all about reporting and metrics. It's going to be good. And then we'll probably have a little bit of a break over summer. And by September 9th, we'll be having likely a pretty significant CPAR CII update. So stay tuned for both of those because there's some awesome content coming your way. All right, last slide. So if you need to sign up to the network, there is the link, okay? And as well as any other questions, you can email emradmin@albertadoctors.org. So thank you, everybody. It's 1:30. I really appreciate everybody joining and taking out the time. Thank you very much to Sarah Joy for starting us off today. Thank you to Leanne, who's our admin and our technical support in the background. Thank you very much to Kristen. And of course to David. Unfortunately, we missed him today, but thank you very much for adding to all the content for today and sharing it with you all. So thank you, everybody. Have a lovely afternoon, and we'll see you on the next quarterly webinar, if not in the next user group meeting. Thanks so much.